So I'm going to speak on OCT in the treatment of calcified lesions. So Nishit has kind of set the platform and already told you that calcium is an important area and it is much better than intravascular. So calcium is the biggest enemy for Indian interventionists. We all know and understand it. Every problem is because of calcium. The catheters don't go in, the long outcomes are bad, the stent doesn't expand, stent thrombosis is common in these patients. So can imaging help? So if we talk of the Indo-China border, unless we have the satellite images, we can't even know what's going on across the border. So similarly, calcium is so important for us that if we can image and find out what the calcium is, we can avoid a lot of trouble. This is a lesion which looks okay. This was stented, and you see the post-dilatation balloon. It's so badly open. So this part of the balloon is hardly open. This is the final result. This patient comes back with instant restenosis. So you don't want this to happen. So you want to prepare this bed. You want to see the calcium properly, because this calcium behind the stent, you can see, was missed. The operator didn't do a ultrasound or a OCT to look at this calcium, so this was missed. If the bed had been prepared well, this stent wouldn't have suffered the restenosis that it suffered. So under expansion of the stent is one of the major reasons of restenosis, and calcium is one of the worst enemies. Now, this is another miserable situation that you have beautiful stent diameters here and here on both ends, but you have just 2.11 area in the center. It doesn't, angiography may not show this, but this is a grossly underexpanded stent, and this calcium does. So this is exactly what Nishit was pointing out about high attenuation and low attenuation. High attenuation, when the light is blocked, you won't see anything beyond it. That's what lipid does. A calcium refracts this light. So if this behaves like a crystal ball, the light gets reflected, refracted, it's bent. So it leads to different attenuation and different kind of morphology of the lesion that appears. So basically a calcific nodule will appear as if it has borders, because the light goes through, but it refracts. And when the border ends, it goes normally through. So this has borders, you can see, but a different texture than the normal wall. So this is the intima we are talking of. This is what the calcium looks like. This is the guide wire. This is the catheter. So this is calcium, which is well delineated. So if you have this kind of calcium, you can calculate the arc, how much arc it is. So it is from 12 o'clock to 3 o'clock. You can calculate the thickness. It will be from here to here. This will be the maximum thickness. And then you can measure on the transverse section the length of it. So you need three things to decide the severity of calcium. So this has been discussed, but I would just add to it that if you have mild to moderate calcium, you could use a non-compliant balloon. And if you have severe calcium, you could have to use an atherectomy, rotablator, or an IVF. You should not venture yourself into difficult areas if there is severe calcium. So how do we decide mild, moderate, and severe calcium? Is based out of how much you have in those three things that we just discussed. Then there could be decalcium, superficial calcium, and nodular calcium, which is a calcium nodule. So let's look at a case. This is a 66-year-old lady, class 3 angina, diabetic. Clearly, you can see fluoroscopically calcium, previous PCI to LED, circumflex, which were patent stents. So we now go for the LED RCA plastic. So this is the balloon, which is a 2 millimeter balloon, which you can see hardly expands. We use this to allow OCT catheter to go in. Hardly expands. You can see the under expansion of this balloon, and this was on high pressures. We put in the OCT catheter, and this is what the morphology of this lesion is. So you see a lot of calcium. So I will show you the arcs and other things in the next slide. So clearly there's a lot of calcium, and you see a calcium nodule in one place. So this is what it is, but you have defined normal and normal area. We have defined the degree of calcium. So we now are ready to do this. So this is a normal vessel, which is the distal landing zone. And this was about 3.5. This is 360-degree of arc of calcium. You can see all along there's a calcium. You see the minimal lumen area. This is after the balloon dilatation with such thick calcium bed there. Another area with calcium and another area with calcium. Now, based on this, we could also define what length of stent the length of calcium is more than 3 centimeters. So this becomes. So now we come to how do we define the length? So based on the normal to normal area, we define the length of the stent, which is 54 millimeters in this case. And once we calculate the length, we know now we'll need 2 stents. So after, this is an IVL balloon. So lithotripsy was done in this particular patient. So you can see the expansion of the lithotripsy balloon. This is a 3.5 balloon, which took some efforts to get in, but it did go in. And once we did the entire vessel with lithotripsy, we checked the result. And you see the cracks. This is the crack in the calcium, this part. You see a crack in the calcium with this lithotripsy balloon. And see, you have made good room for the stent to come in. We were not satisfied in some areas. We went with a non-compliant balloon to further dilate after the lithotripsy and then placed in the stent, which was 3.5 millimeter distally and 4 millimeter proximally. And then we went ahead, post-dilated with 3.5 and then 4 millimeter balloons, and obtained this kind of result angiographically. So which also looked quite reasonable on OCT, as you can see here. This is the result on OCT. We try to look at distal dissections. There was none. And reasonably well expanded stent that you see going up to lumen areas of 10 and more. So this was what we had, and this was the final result. And you look at the stent expansion, reasonably good. So what about a calcified nodule? A calcified nodule is like this on angioscopy. You see shells of calcium protruding into the lumen. So this is a very nasty thing, because treating this is not easy. Rotablator is a good technique, but what happens is that sometimes there is a wire bias towards the normal part of the vessel, and you are not able to shave the calcified nodule. Non-compliant balloons will dilate the normal vessel, not this part of the calcium which is protruding into the vessel. We don't have orbital atherectomy. IVL balloon may help because this is very superficial calcium. So calcium nodule is seen in 2 to 4% of patients, irrespective of the clinical presentation. More common in RCA. We saw calcified nodule in the case that I showed. More common in patients with CKD on hemodialysis. There is generally an additional calcium present in the vessel, generally more than 180 degrees. Look at this nodule. This is a pre-calcified nodule. This is after ablation with a rotablator, a fracture here, and post-stenting you see a good result. Another calcified nodule you see protruding into the vessel. So this is a brief scheme of how calcium can help you to diagnose. So based on this criteria, calcium arc 180 to 270 degrees, 2 points, more than 270, 3 points, calcium length more than 5 millimeter, 1 or 2 points, thickness more than 0.5, 1 point. If you have 1 to 2 points, high pressure balloon would be adequate. If you get a suboptimal result, go for lithotripsy. If you have 3 to 5 points, you could choose between rotablation on lithotripsy. Lithotripsy is expensive, but many people can do it. Rotablator requires some special skills, but I guess we could have similar results with both. So if there is an uncrossable lesion, so if the lesion cannot be crossed, you have no option but rotablation or an orbital atherectomy. So this is what calcified nodule looks like. So it's defined as calcium nodule which protrudes into the lumen. If we look at patients, we could have distribution more commonly on the RCA, but calcified nodules could be associated with acute coronary syndrome. As you can see, studies of STEMI and ACS also showing similar things, that calcified nodules could be present with these kinds of patients. Let's look at another patient. So this is a circumflex artery. We have a lesion from here to here. Doesn't look so bad. Most people would just go with a NC balloon and dilate it. But let's look at what we have in store on the OCT image. So this is a running image, and you would appreciate what I'm going to show you is a big calcified nodule. It comes here. See that it came from the 3 o'clock position. So you could clearly see a calcified nodule. I will push it again back to that area. Okay, you run. So a calcified nodule can actually cause a lot of problems in dilating. Suppose we have this kind of a calcified nodule. You have a wire which is lying on this side. If you do a rotablator, we'll be able to cut this calcium. However, if you have a wire lying here and you want to cut calcium on this wall, you may find it difficult. For example, in this nodular calcium may not cut, and you may cut this part with the rotablator. So the wire bias is very important, and OCT helps you to assess where the wire lies and where is the wire bias. This is another patient which we did a rota with a scoring balloon, but I'll show you what we want, what is in the left main. So you see this is the LED stent which had an in-stent restenosis and an austere restenosis, but the left main, as you saw in angiography, looked reasonably all right. But let's see what it appears on OCT. We come to the left main now. See a big calcium nodule which is bulging into the left main, makes it very elliptical. It loses its normal round texture and becomes very elliptical. We got away doing a scoring balloon followed by high pressure balloon with a decay crush, and finally got a reasonable result in this patient. And OCT again helps in assessing. But you can see that despite whatever we did, still there is a bulge of the nodule. We have not made this circular as we had wanted to do it. And this is after the final kiss and final balloon. So as I would conclude my slide, it is very important when we talk of calcium, we look at these 3 points, because OCT gives you exactly these measurements, which I always finds it very difficult to give. This can help you to guide what procedure you want to do. So use of IVL or rotablation would be very useful in some patients who have multiple reasons to believe. So this looks very innocuous lesion, not much calcium on fluoroscopy, and we couldn't cross with a balloon. This is the rota that was brought in immediately. And now look at the calcium. So there was a nodule. This is after rotablation. So the rota has been able to cut this nodule, and we see some cracks through this calcium, and we look at the arc, which is large, and this was finally stented, and this is the final result after post-dilatation, which is reasonably good. I would thank all of you for being there. I tried to cover up as much as I could in the 15 minutes that I had.
Thank you. Thank you very much, Balbir. So we will just go to the next presentation, which I think is mine, and then maybe have the 4th presentation and then go on. So